Welcome to the National Hispanic Cannabis Council Educational Committee Forum on Cannabis 101, where we bring medical professionals together to demystify the health and wellness power of cannabis and to help break down the Latinos' long-held cultural taboos and beliefs on cannabis. My name is David Sanchez, board member of the National Hispanic Cannabis Council and Cresco Labs' VP of Product Development. Today, we're bringing two cannabis doctors and my partners from the NHCC's Board of Directors, Dr. Phil Burns and Dr. Craig Ontel from New York State of Mind, and my colleague, Dr. Chanel Law from Cresco Labs to discuss cannabis and depression. A little bit about myself. My name is David Sanchez, and I've been in the cannabis industry for over a decade now, starting in small labs and growing them to large-scale manufacturing facilities. My background is in chemistry, and my passion really lies in helping people understand the benefits and the power of cannabis. My journey has been extraordinary, and seeing the beliefs and seeing the efficacy of cannabis throughout my cannabis journey has been incredible, and I want to share that with you guys today. A little bit about our guest today, Dr. Craig Ontel. He trained at the NYU's Rusk Institute of Rehabilitation. From there, Dr. Ontel has spent nearly 15 years of private practice in NYC. He also served as a director of the ambulatory orthopedic rehabilitation at NYU Langone's hospital system. In May of 2021, he left NYU to become the CEO for State of Mind Cannabis. Dr. Ontel has personally treated hundreds of medical cannabis patients over the past few years and has had significant success in weaning patients off of narcotic-based medicines and substituting with non-euphoric, non-sedating cannabis-based options. Dr. Ontel has been published in numerous cannabis articles and has presented at national conferences. Welcome, Dr. Ontel.
Thank you, David, for the introduction.
Yeah, and for our second guest, Dr. Phil. Dr. Phil Burns is a DO and has been in practicing medicine for over 20 years, completing specialty training in the field of physical medicine and rehabilitation at NYU Langone's Health Rusk Institute of Rehabilitation Medicine. Upon completing that training, he founded and has operated a successful medical practice specializing in orthopedic rehabilitation as well as prosthetics. Dr. Burns is driven by his desire to make a meaningful impact in the state's opioid crisis. Welcome, Dr. Burns. And last but certainly not least, Dr. Chanel is our senior scientist at Cresco Labs, bringing over 10 years of research experience in chemistry, as well as macromolecular science and nanomedicine. Her experience spans working in chemistry, biochemistry, pathology, engineering, and medicine. Dr. Law now serves as a committee member of the Academic Clinical Research Committee, overseeing research on differing routes of administration, new medical conditions, symptomatic treatment, in vitro and in vivo, as well as clinical trials with medical marijuana. She is a PhD in chemistry from the University of British Columbia and has developed novel compounds designed to target valuable blood components and has documented their translational applications in peer-reviewed publications and patents. Her multidisciplinary experience ranges from the Center of Blood Research working in Vancouver to the University of Michigan's Medical School. Since joining Cresco Labs, Dr. Law has applied her scientific research expertise to medical cannabis research and has led her team to the development of novel cannabis formulations, methods for chemico-physical characterization, and is data-driven drug stability and supporting the organization's goal of professionalizing cannabis. That rounds out our panel. Thank you, Dr. Law, for joining us today.
Thank you, David, for the introduction.
Of course, of course. And with that panel, and before we get started, I did want to say a couple words about the NHCC's mission, which is to educate the U.S. Hispanic cannabis community on the health and wellness aspects of cannabis to empower their support and their participation in the industry. Our aim is to help demystify through educational programs such as this one, and to really help educate and break down those cannabis long-held cultural taboos and beliefs on cannabis. So without further ado, let's begin our topic of discussion for today, which is cannabis and depression. Doctors, where do we begin?
Whew, that's a great question. And thank you for having us again today, David.
Of course.
This talk was a little more difficult than the other ones we've done, because usually we can show up here and we have a nice amount of research behind us, and we're able to really push forward the positive aspects of cannabis and depression. This one's a little harder. There's not a lot of objective studies out there, so we're going off more subjective data and some anecdotal stuff. And at the highest of levels, the relationship between cannabis and depression is complicated, because in some patients, cannabis can elevate their mood, and in other patients, cannabis can worsen their depressive symptoms. And we're also looking at a bi-directional medication here, where based upon dosage, people will get different responses. And a low-dose cannabis product might give someone a euphoric experience, where if someone takes too much, they might have more of a depressive experience. So that makes it difficult. And then where do we begin is, as doctors here and healthcare professionals, you really have to know what you're treating before you treat it. So we need to take a look at what is depression, and who has depression, and why do they have depression. So there's different types of depression. There's something called seasonal affective disorder, which I'm an open book. I had like a decade ago here in New York. It rained for the whole month of June. I was depressed. I'm the happiest guy alive. I never saw the sun for a month. I was depressed. That's a cause and effect, and it's short term. There's major depressive episodes where someone has been following with a healthcare provider for a while, and based upon the criteria, they have a true depression. There's a persistent depressive disorder where someone is long-term for greater than 2 years. You can have a postpartum depression, which a lot of folks have heard about. And then you could be depressed because of pain, which is hopefully short lasting, or a certain situation. So it's really identifying what your cause is before you start to treat. And then before I hand this off to my colleagues here, always speak with a healthcare provider and make sure that you have the right diagnosis for what you're trying to treat. Never forget, cannabis is a medication similar to anything else you would show up at the pharmacy to get.
That's a great place to start. And, you know, it seems like what you're saying is there's a lack of studies, but then also the studies that have been done have been a little bit of a mixed bag. Am I hearing that correct?
You are. So there's really a lack of double-blind, placebo-controlled studies. They just don't exist, where a patient is given a cannabis product versus a placebo. They're followed for a period of time, and their results are monitored. We just don't see that. And a big reason for it, besides the Schedule I of the drug, where companies aren't really able to do the research, is depression is not one of the accepted conditions in the medical programs. That's probably going to be a surprise to everyone on this call and everyone watching this. When we look at the criteria state by state, depression does not check that box as an accepted indication for cannabis prescribing, unless we're in a state that has a carve out that says, as per doctor recommendation.
Interesting.
And that's a big reason why we're not seeing anything even state driven on it.
Wow, interesting. Okay, and so who is eligible for depression medication, or how does someone go about getting diagnosed? What does that process look like?
How does someone get diagnosed for depression?
Yeah.
By speaking to their trusted healthcare provider, and there's certain diagnostic criteria for each of the depressive disorders that Dr. Antel previously mentioned, from major depressive to bipolar to seasonal affective, etc. And working with starting with their primary care, referral to healthcare mental health experts. They can work through and make the correct diagnosis, and then from there determine what treatment plan would be appropriate for them. But really honing down on root causes and getting a specific diagnosis is most helpful in when we look at outcome and positive.
We also have a handbook that we go off of. So it's one of those secrets that patients don't know, and we don't use it, but in the psychiatry world they do, and it's called DSM. And I'm not sure what number they're up to now, but do you want to touch on that, Dr. Burns, for a second? Or you want me to keep running with it?
Run with it.
I'll keep running. So the DSM, it's a book that we use, and it gets updated every year or so, and it's what the healthcare providers use. And there's a checklist of criteria that folks need to meet in order to be given a definitive diagnosis.
Interesting. And so how does cannabis affect depression? Or does it modulate it at all? Does it have any impacts? What have some of the initial studies shown?
I can hop on that one too, guys. So, affect depression. We're gonna, first off, it affects the endocannabinoid system, which is the body's homeostasis regulator. And it affects something called the CB1 receptors in the brain. So we make endogenously or internally a natural compound called anandamide. And that's the happiness compound in our body. And it what makes us happy. And we produce it. Over time in the pharmacology world, we realize that serotonin is one of the neurotransmitters in the body that in people who are depressed tend to have a low serotonin level. So we have created pharmaceutical products that help to raise the serotonin in the body. Serotonin binds to the same receptor as the anandamide. So that same happy receptor.
Interesting.
Cannabis binds to that receptor. So cannabis binds to the happiness receptor at the highest of levels, pun intended.
Right. So the CBD in cannabis affects one of the serotonin receptors, 5-HT1A. So as Dr. Antel noted, lower serotonin levels are associated with depression, and the pharmacology that exists to treat depression seeks to elevate the serotonin levels. So it stands to, the conventional wisdom is that an elevation of the serotonin, and hopefully through CBD can elevate serotonin levels and thereby have a positive effect on depression. But again, the research is still trying to catch up to show that clinical correlation.
Interesting. And is there any designation in the research for type of cannabis or marijuana? There's a lot of let's say a general consensus that a sativa dominant plant or strain is going to be more euphoric or more happy-go-lucky, whereas an indica is going to be very sedative and lazy, call it. And so is the research using any type of specific marijuana, or are you saying it really comes down to the compounds THC and CBD that are binding to these receptors? It's not really a matter of the strains, call it the terpene profile or the flavor profile. It's more of that active ingredient. Well,
Maybe I can hop in a little bit. So definitely there are significantly more studies that are focused on the cannabinoids and the ratios of the cannabinoids. But I don't want us to kind of neglect the synergistic effects of terpenes that have been studied. And that's definitely something that's being worked on currently in a lot of clinical trials. Granted, a lot of them are limited to one state. And because of certain FDA limitations, you can't necessarily claim that that formulation is for one application. But what we can do is have a lot of patients provide their self-reports on various symptoms arising from their depression. And we have seen some positive data, especially in terms of CBD use for symptoms of depression, which is very encouraging. And there's definitely a positive outlook if we can expand some of these studies to reach beyond these kind of narrow demographics that they're currently focused on.
okay.
Absolutely, Chanel. And, we have identified that certain terpene profiles and certain cannabinoids have a positive effect on depression, whether it's linalool or mycerine or carophyllene. These we have identified. Getting back to the sativa indica, and we have a hard time answering that because it's such a, it's a catchphrase that people like to use, and there's so much variation across the board. But if I was to keep it real general, the sativa-based products, anecdotally, or the feedback from the patient pool, tend to do better for folks who are depressed. Your sativa-based product tends to get you up and going. And your sativa-based products can affect dopamine in the brain, which gives you energy and gets you up and moving, so you feel better. As a general, and I'm being general and I apologize for it, your indica-based products tend to be a little bit more sedating. Folks who are depressed are sedated anyway. They are removed from society. They are not interacting. So if they use an indica-based product that's going to put them deeper in the couch, that response really is not there. We are not seeing benefit in depressed patients who are only using a THC product. We are not seeing benefit in patients who are using a high THC and a low CBD. The depressed patient population seems to respond better to a lower THC, higher CBD formulation.
Interesting. And for these formulations, are people seeing the best efficacy in inhalable applications and products, or are these ingestible products? What are some of the research's studies methods?
So currently, that is one of the limitations of the studies. It becomes a little bit challenging to hone in on the method of administration. First of all, because the physicians cannot actually have the product to provide to the patient. It's difficult to confirm their route of administration aside from the self-reports. And in the self-reports, because there are many limitations and variations state by state in terms of what is allowed, what is not allowed, and what's available at the dispensary, it's challenging to correlate it to a specific route of administration currently.
Interesting. And so if the marijuana programs, the medical programs, are not allowing depression as one of the qualified conditions, but people are still using cannabis as a way of treating depression, is there risk to long-term users? Is there something that patients should know about if they're using this?
You have a risk of cannabis use disorder, and it's real. And that's the medical term that we use for an addiction to cannabis. It is. And that's real, and that's there. And the prevalence is highest in the adolescent population that start with the cannabis product. And we're seeing that occur, and we are seeing a higher incident in some psychoses and maybe even some schizophrenia. This is really variable. And you know, you got to take a real good look at someone's background and their family history and their genetics. And you want to make sure that you're not setting that patient up for failure or further problems down the road. And what Chanel was mentioning before, for us, is really hard. And we were on just a chat before we hopped on this, just for the folks who are watching this know. And we were talking about the variability from state to state in products, and how Dr. Burns or myself could start a patient on a specific product in New York that works for them, and it's got a specific chemical composition. Unfortunately for us, the second they're out of New York and they're in another state's program, that product doesn't exist.
Yeah.
So you really have to start over again, and your hypothetical 5 milligram gummy of XYZ strain is not the same from manufacturer to manufacturer, not even close.
Yeah.
So until we get more of that consistency across state lines, it's going to be very difficult for us as healthcare professionals to fine-tune what we're doing.
That's a very excellent point. Beyond that, what we're also seeing is, for some studies, because the dispensaries tend to be located in city centers and very populated areas, sometimes we're actually also having patients unable to find these products on, say, certain parts of the state, or, you know, sometimes we end up getting demographics that are really just, say, 10% of the area of an entire state. And it can be very challenging for patients, especially when manufacturers sometimes discontinue a product, which products do change quite quickly in the cannabis space. I could not imagine what it must be like for you to follow a patient's trajectory on their specific product that they're utilizing.
Oof. And so I think I'm hearing Chanel say access, right? And I think not a lot of folks have access, one, to cannabis products, cannabis care, cannabis information, and two is just general mental health treatment awareness. Can we speak a little bit about mental health access, at least specific to New York? What does that landscape look like? And then how much more challenging is it for folks to take it one step further and then say, hey, I think I have something that I want to get checked out for mental health, and is cannabis right for me? What does the landscape look like there?
You know, again, I think that starts with speaking to your healthcare provider and letting them sort of quarterback your journey through this, in terms of getting you dialed in with services to provide assistance, confirming correct diagnosis, and overseeing your overall treatment plan, whether it's pharmacological, psychotherapy, cognitive therapy, behavioral therapy, other ancillary things, sort of such as exercise, acupuncture, what have you. But really sort of getting a correct diagnosis is where this starts from, and then determining if cannabis product is right for you in respect to sort of other social or medical picture. And then from there, like Dr. Antel and Chanel were saying, choosing a strain that's appropriate for you and provides you with not only respectful of your type of depression, but something that's going to give you sort of the entourage effect of a whole of flower type of approach where you're getting not only the correct CBD, THC ratios, but also the terpene profiles like we discussed. And, sort of the best selection of treatment plan should lead to the best overall outcomes.
And we're also going through a mental health crisis in this country, and everyone who's watching this is well aware of what's going on. And, I could speak from my seat sitting in New York, where we have a true mental health crisis here. Statistically speaking, 24% of the US population doesn't have access to mental health care. They don't. So that's a lot of folks out there who are self-treating. Then if we take a look at where these cannabis healthcare providers reside, and I can only speak from the state I'm in New York, we have counties in this state that have literally one or two cannabis providers in the whole county.
Wow.
So even if you had the wherewithal to seek out that care, I mean, you might have a 50 or 100-mile drive just to see that individual. And then, and once again, I'm sitting in New York, we have maybe 40 medical dispensaries that are operational in a state of 19 million people.
Wow.
So it's just not there.
Yeah.
Like you can't even, a lot of these patients can't even access an appropriate medical dispensary because it just doesn't exist. So there's a lot of infrastructure that still needs to occur before patients are able to get that proper healthcare from a medical cannabis perspective.
In terms of infrastructure, this actually is a question that just came to mind. I was thinking through one of the advantages of getting your products from the dispensaries is you have access to the wellness advisors who are in some states certified pharmacists, and they have a lot of knowledge on the formulation of the products as well as the response from various patients as they continuously interact with them. Is there currently any infrastructure in place for communication between the referring physicians and the wellness advisors, or is that something that maybe we can discuss embarking upon going forward?
That's up Phil's alley. Go ahead, Phil.
The system could be better. Is the truth.
So yeah, historically, I am a New York cannabis doctor, and I had maybe, when all said and done, I probably had about 1,000 active patients in a system that maybe has 100,000. So I have a fair amount of experience in this, to say the least. And when I was practicing full time before I left, I never had any feedback from any of the medical dispensaries that I referred my patients to, because they weren't allowed to get back to me.
Oh,
Yeah, not good. So that just was, and I always wondered, like, wouldn't you want to market me? Wouldn't, like, it'd be nice to get some feedback, anything? No, they weren't allowed to. It was very segregated, separated out. It was bad. That has softened right now. And big concern here is patient access, communication, and education. So the way it was working historically is, a physician like Dr. Burns or myself would write a prescription and that patient was off in the wind. No feedback, nothing. And even when they went back in for their renewal, still no feedback. And to us, that's key, because we need to know how that individual is responding or not responding. Otherwise, we're no longer managing that care. Yeah. And the situation that we worry about is that patient self-treating at that point and saying, well, the doctor said 5 milligrams of something is right, but I got a high tolerance to everything. I have to take 2 Advils. So I'm going to take 10 milligrams. And now they start going down that path where they're self-treating and they're chasing something that they're not able to attain. Yeah. That's a problem.
Wow. And so with all this being said, there's a lack of access to the system could be better in terms of getting communication to and from the patient, to what you're saying, managing the care. And so what are patients left with? What are the other solutions to treating depression? What are some of the current solutions out there? I know we see a lot of infomercials, commercials on depression medication, but are those the current solutions, and how does that differ from cannabis treatment?
What we were taught as medical residents and students is the best treatment for depression is a half-hour walk in the woods. I swear that's what they taught us. Get out into nature, get back to yourself. So I'm saying that because that's true. Mental health and depression in the open quotes pharmaceutical world is huge. It's tremendous. So there are psychologists who would practice in more of a sit-down talk therapy. There are psychiatrists who do that. There's pharmaceutical-based psychiatrists who do it as well. There's feedback, there's therapy programs, there's relaxation, there's so many different avenues that folks try to treat their depression. How we started this conversation today, I'm going to circle back to for a minute. It really depends on what you're treating and what the root cause is. And for all of us healthcare providers, the four of us sitting here, that's always the most difficult part for us. And as soon as we're able to identify that, we'll get the rest of it's simple. And I'll use an example. Pain causes depression, period. You're in pain, you can't function, you're depressed. So are you going to try to treat the depression, or are you going to try to treat the cause of the depression, which is the pain? We have lots of studies on how to treat pain with cannabis, and we've been very successful that route. So for that individual, him or her, that's the route one would go. It's really identifying what that root cause is.
Interesting. All right. And if we had to boil down the hour in our conversation and today's discussion, doctors, let's get to the bottom line question. Do you recommend cannabis for treating depression for your patients?
It's a case-by-case thing, and I'll answer that, and then I'm sure Dr. Burns has an answer too. Like I said, I really need to know the root cause. I'm an objective doctor. I don't just treat. I want to know what the problem is, and then I treat it. Certain folks, I'm not touching cannabis at all. So if someone comes in and I know they have a substance abuse history, and the substance abuse was caused because they were looking to that substance for a solution to something else going on, we know we're running into the same problem of cannabis.
Yep.
They're just going to keep getting deeper and deeper and deeper because they're looking for something that they might not find. So that's a red flag to us right off the bat. Another one is you got to look at the age of that patient. And there is a strong concern that I hold personally in treating adolescents and the younger patient population whose brains are still developing with a cannabis product. Because there is data and research out there that shows long-term that's not a good option. And there is a higher percentage of other psychological disorders that one can kind of map back to that cannabis use.
Dr. Burns?
Yeah.
Your take?
Yeah, so typically the treatment plan starts with pharmacology, whether it's a SSRI, sort of the Zolofts, Lexapro, Paxils, Prozacs of the world, or an SNRI, which is a serotonin nursery, so like a Cymbalta, TCAs, MAIOs, etc. So one of the pharmacologic medications usually starts with. And then psychotherapy, speaking to somebody, getting to the root cause of the depression. All depression's not the same. People's life history and concomitant medical picture is different. So it's difficult to sort of generalize, but its use as an adjunct should be examined. But like I said, depression is real. If someone has hallucinations or suicidal ideation, obviously they need help, and they need help quickly. And we would just encourage everyone to seek out the help. It's there, from hotlines to their personal doctor, family, friends. If someone has sort of concerns about social stigma, everyone goes through periods of, depression at various times in their lives. And they really shouldn't feel sort of any kind of stigma or ostracized, or, they'll be sort of looked upon differently. The help is there for you. Seek it.
Yeah, that's great. And I think it's important for people to hear that. I think it's comforting, and acknowledging it. To hear from you guys is very powerful, because we want people to feel better. We want them to have a better quality of life, even if that means strolling through the woods, right?
Yeah, it is. And, this table or this piano right now is being lifted by us. It is. It's being lifted by the folks like Chanel, who's sitting here, and Cresco and State of Mind, and the other companies that are really doing the research on our own end and are really trying to figure out how to better patients' lives. Unfortunately, like I mentioned before, as long as this drug remains a Schedule I drug, there's not a lot of federal studies or any of that, and folks really are handcuffed in doing the research. But I could speak for all four of us sitting here. We put our head on the pillow well each night, and we sleep well knowing that the work that we're doing is to better people's lives, and we are making a difference, all of us here.
Couldn't agree more. What else do we got on cannabis depression, ladies and gentlemen?
I'll kind of wrap it up a little bit. So, this was a tough one for us. And usually we can sit here, the three of us, and we can ramble off this, that, and the other thing for people. And they watch these podcasts, and they head off to their dispensary, and they're armed with the knowledge they need. They walk in, they do their mic drop, and off they go. This one's harder, folks. It is. This one will be one that we'll likely circle back to again in 6 months or 12 months as we get more research and we get some more updated information. And, I'll call this one a work in progress.
Yeah.
However, absolutely, it can make a difference if it's used in the right clinical setting for the right individual. It helps. And it's all about the homeostasis, which is the body's internal regulation. And that's where cannabis works. And I can sit here and I can confidently say that what we don't know today, we'll know in 6 months or a year, and the science will move forward.
Perfect. Well, thank you for those closing remarks. I just wanted to thank.
I want to touch on one more thing. Sorry to interrupt, but it's very important.
Please.
And Chanel mentioned it before. And anyone who's watching this, please do not self-treat at a non-licensed cannabis facility.
Yeah.
You are taking a big risk. You would not go to a non-licensed pharmacy to get your blood pressure medicine or your diabetes medicine. You're looking at this as a medication. If you go to a licensed facility, it's been tested for impurities, tested for toxins. You know exactly what you're getting. Otherwise, you do not. So I said it twice. I'll say it a third time. Please stay within the lanes. There's no reason to swerve.
Great call out, Dr. Antel. In closing remarks, I wanted to thank you guys, our panel, Dr. Law, Dr. Burns, Dr. Antel. Thank you guys so much for your time and for the information that you brought to today's discussion. I also wanted to thank the NHCC for hosting this educational seminar and for continuing to bring cannabis information to the people watching. Thank you guys so much.
Thank you.
Thank you.
Thank you. Have a great day, everyone.